Good afternoon. So we will start even if 1 minute before, better before than later. It's a pleasure to be here, and it's with much pleasure that I anticipate the objectives of this session that will be for 45 minutes with the support of Medtronic, together with my colleagues and friend, Professor Bruno Scheller, Dr. Hildrik Smith, Dr. Kambis Machachesis, Dr. T. Keong, and Dr. Fausto Castriota. I think I am not forgetting anyone. Yeah, I mentioned all of them. This is a session, very practical session, on how do I confidentially expand my DCB practice. So we all hope that you have started your DCB practice so you can expand it. And the reason why you are here is because you want to identify what we intend as an appropriate lesion preparation. This is key. This is the basis to start with when we have in mind a strategy that would end with the use of a drug coating balloon. We will try to share with you a basic concept needed for a good DCB immediate result. You know that the immediate result will not look as nice as a stent, but it's the promise that it will look much better when you make the follow-up of this patient eventually, and it has very good long-term clinical results. And then to learn about, indeed, the long-term angiographic and clinical results of this new technology. So it's with much pleasure that I will invite the first speaker, Professor Hildrik Smith. He will tell us about which lesions should be considered.
Thanks very much, Flavio, and thanks for inviting me to this session. So, lesion selection and preparation for drug-coated balloon PCI. I have to say that about 18 months ago, or thereabouts, I had pretty much a Damascene conversion, which I won't bore you with in too much detail, but I did begin suddenly to see the flaws and limitations of drug-eluting stents with their inevitable year-on-year decrement of clinical events, stent thrombosis, malapposition, etc., need for antiplatelets. And I suddenly thought, actually, maybe these drug-coated balloons could be the thing that we need to consider a bit more. And pretty much overnight, my mental approach to angioplasty changed. And it changed from, I'm going to put a stent, how long should it be, how big should it be, what pressure should I put it in? And it changed to, should I place a stent? Do I need to place a stent? And if I do, why? There has to be a good reason. So, perhaps initially, you might consider starting with lesions such as this one. This is an 82-year-old man with definite angina, in whom clearly the most severe narrowing is right here in the mid-LAD, unencumbered by other branches. That was predilated with a 2.5 millimeter balloon, and then a 2.75 by 15 millimeter Prevail paclitaxel eluting balloon with a nice angiographic result. If you look very carefully, you can probably just about detect some linear dissection, but that's what we're trying to achieve. And so, because I thought, okay, well, we're ahead, we're winning, let's treat the diagonal as well, because that's actually a 2.5 millimeter important vessel for this man as well. So predilatation with the 2.5 by 20 millimeter balloon, and then a 2.5 by 30 millimeter drug-coated balloon with a perfectly good angiographic result. TIMI3 flow in both vessels, perhaps some visible dissection, perhaps some slight underdilatation at the ostium of the diagonal. I might have done that differently now, but the end result is good and the patient is happy. And actually, having gained some experience by doing that and really looking at every case with the possibility of drug-coated balloon therapy, before long, I think it's perfectly reasonable to approach a case like this. So this is a late presenting STEMI. Obviously, the right is occluded. There's a little bit of thrombus. So after thrombus extraction and predilatation, with, I think, a 3mm balloon. Nowadays, I'd use a 3.5. We then took a 3.5 by 30 drug-coated balloon, dilated the vessel, and got a very nice result. Now, the patient is spared agonizing over the duration of long-term antiplatelets. They've got their rheology of the vessel restored, maybe endothelial function. You haven't got risks of malapposition. You haven't got risks of stent thrombosis. You haven't got to manage with the orthopedic surgeon what you do around their antiplatelets when they need a hip replacement. So, you know, I must say it was, for me, quite a revolution. And you might say, okay, fair enough, but what does it look like in a few months' time? You know, is this a durable result? Happily, for me, not for him, happily, the patient came back in 3 months, and here you can see an angiogram of that same vessel. We've had surprisingly few patients come back for clinical episodes. This was a clinical episode on the left-hand side. And actually, if you compare the results of the angioplasty itself on the left-hand side with the result a few months later, I think you can see what you would expect, which is that the previously slightly vasoconstricted vessel has now dilated of its own accord. All its motility is restored. It's probably more like a 4mm vessel, but actually if you'd stented it, you'd have put in perhaps a 3.5 at the most. You'd have basically undersized it compared to the reality of the vessel once some of its health was restored. So for me, this has represented a massive shift in how I do angioplasty. And I think so far, because I'm by no means especially experienced at this technology, we have far more experienced people on the panel, but for me, I've learned 3 key things. So the first is you must dilate the vessel properly. So we're used with stents sometimes just to making a space so that we can deploy the stent. That's completely wrong for this technology. You need a therapeutic dilatation. You need to use non-compliant balloons, cutting balloons, lithotripsy, as much as you need to get proper dilatation of the vessel. There's no point leaving the vessel undilated and then placing a drug on it. Ideally, angiographically, you want a less than 30% restriction at the end compared to the start, and you need to keep going until you relieve the obstruction. No point doing the balloon until you've done that. And remember, of course, angioplasty means dissection. If you can't see the dissection, maybe you haven't done enough. Angiographically, we only see a dissection maybe 20% of the time when we do pre-dilatation, but if you did OCT, you would see that dissection 95% of the time. So that's actually the mechanism whereby angioplasty works. So that was the first thing I learned. The second thing is you need to get TIMI3 flow. So TIMI3 flow trumps a lot of the other characteristics. It can be pretty ugly at the level of the dilated segment. It can be something we're not used to, dissection, lucency, etc. But if you have TIMI3 flow, that is a key thing that you are looking for. You only need then to stent as a bailout phenomenon if you have, for example, a spiral dissection or an occlusive dissection, obviously, or persisting dye staining in and around the media and adventitia. And the third thing I learned is that the balloon, the drug-coated balloon, is not actually for vessel dilatation. So it's a sort of a misnomer. Yes, it is a balloon, but you're not using it to dilate the vessel. All you're doing, all you're trying to do with the balloon is lay the drug on the dissected inside of the blood vessel to allow prevention of the restenotic process. Try it. You might like it. Thank you very much.
Great, fantastic presentation. Before we go to the questions, you are invited to poll your questions via the app, and we'll get it here on the screen and try to answer it during the session.
It's working.
So Dave,
Should be working.
may I ask you, I mean, I know you really as an excellent scientific researcher, and that was basically one of the first eminence-based talk I heard from you.
Yes, yes.
So do you have any data?
Quite little, personally. So yes, so it was a leap of faith, and I think you know you spend years accumulating data in various areas, and over the last 18 months, I've been preparing possible studies to do in this territory. But yes, it was very much a leap of faith of trying it and seeing from the cohort that we treated, did we get any comeback? Did we get the kind of things that people would fear initially, which is immediate occlusion, 4 hours later with bad outcomes, etc., etc. And actually, the more we advanced and the more we tried, the less we found complications and difficulties, and therefore, the more encouraged we were to carry on. And I completely accept your point that really this has been a leap of faith, but it's a leap of faith which I think you need to take in your practice, allied to the data that's accumulated in lots of other spheres with drug-coated balloons, and then maybe do analysis of your own data to confirm that you are getting the good results you hope for.
Yeah, taking this leap of faith, you call the patient back after 3 months. This is a rather short period. Is it that because you were not sure about the result, you were concerned? Why not after 9 months or a year?
No, he was just somebody who happened to come back because he had angina, and in fact it was left-sided disease. So in fact we happened to get another angiogram. We've had, really surprisingly few patients come back for us to be able to actually look at the result, because of course ethically we're not allowed just to call people back for angiograms.
So have you stopped using stents in your practice?
Actually, pretty close to that, pretty close. So put it this way, every angioplasty I do now, I will do thinking, can I do this with drug-coated balloons? And only if I can't, will I then consider, okay, fine, we need a stent. So it's really a bailout phenomenon for me now already.
So it means that there is no contraindication, there is no lesion in which you would not consider it.
One of the funny things is that the hottest lesions of all, and the lesions which I personally think we stand to gain the most for with this therapy are STEMI cases, and I've been very happy and extremely pleased with the results we've got there. They're the very patients in whom, when we place a stent, we're often doing a bad thing, undersizing the stent in a vasoconstricted vessel in a vasoconstricted patient.
We have, with this short question from the audience, the question is, do you think that in the case of STEMI with thrombus, there's enough drug transfer to the vessel wall?
Yeah, so I think, and I don't know the answer to that, but I think what I've certainly been doing is using the thrombus extraction quite liberally, because of course if you just apply drug to thrombus, well, the thrombus is going to wash away. But I think my approach to STEMI has changed completely. So it's now thrombus aspiration, delivery of a glycoprotein inhibitor, and then application, once we've dilated the vessel, of a drug-coated balloon. And I'm really impressed by the results.
Two questions. One is that when I size for stenting, I size for luminal. I measure EEL, and I try to get 90% luminal gain based on my areas.
Yes.
And if you're doing this, do you undersize? Because if you have a medial dissection with hematoma, I think I would be a little resistant not to put a stent in. So are you purposely undersizing in this situation, unlike going for EEL for the biggest volume? That's number one. And number two, when I was doing angioplasty, when most people were still being born, we acute MIs. I remember I thought I had a great result, and 15 minutes later the vessel would close. So I think personally I'd be a little afraid to not stent in an acute MI.
Absolutely, and I understand your fear, and I think it's a fear that lots of people would share. But I think we've forgotten a lot of the lessons that we learned very early on doing angioplasty. Angioplasty is dissection. That is the mechanism by which we actually increase the lumen. So if we think we've done a beautiful angioplasty by just squishing the lesion, we haven't. We've actually caused a dissection. That is the only way you make the lumen bigger. So you have to cause a dissection in order to be able to lay the drug on and prevent the restenotic process. So in answer to your question, no, and I know you use OCT, I think, for every case of yours, so you're less likely to undersize things than other people. But we're deliberately not undersizing. I think undersizing is a mistake. If you undersize, you don't get adequate balloon dilatation of the vessel. You don't get the dissection that allows you to lay the drug on the luminal wall of the vessel. So sizing 1-to-1 is really important, I think.
Do you image all the time with DCB?
That's a separate question, and I think it's possible that it's less important than it might be for when you're putting a stent. I think if you're putting a stent, it's really important to know absolutely the vessel's size, because you're going to be leaving that implant there forever. So you don't want to undersize it. For the drug-coated balloon, it's slightly less important, I think, to image every time, because you are not leaving any permanent implant there. Now, it's a different argument and could be argued either way, but I think it's probably less important.
And you don't know, Rich, where to look at. We don't have data, as far as I know, which are imaging related to a good DCB result.
But you do know you want to pre-treat.
Sure.
If you have a calcified lesion,
It's absolutely essential. It's absolutely essential to do a good plaque prep. Agree. Yeah.
spreading out, you know.
Please.
In your experience, which is the best drug you use? Sirolimus or Biolimus or Baxter?
So I don't know yet. I mean, it's interesting. I tell you, we all assumed that sirolimus was going to be better because it was better for stents. But actually, there's some published data to suggest that may not be the case. So I think we have to wait. There's going to be a lot of issues around the way the drug is delivered, the drug kinetics, the actual dose of the drug that's delivered, etc. So I think that one's going to play out over some years.
A provocative question. I love drug-coating balloons, but I remember that 30 years ago we have no stents, and the main problem was with elastic recoil, not with neointimal hyperplasia. So why does it work better than plain balloon?
Yes. So the reason I think that things have changed completely is that exactly what you said. We didn't previously have stents. So previously, people would take an undersized balloon and timidly blurt up a bit, because what they feared terribly was spiral dissections and occlusive dissections, which they couldn't deal with because there was no technology. Now, we can pre-treat 1-to-1, we can be more emphatic, we can use higher pressures if we need them until we make sure we've dilated the lesion. And of course, we have the absolute luxury of knowing that if we're unlucky enough to get an occlusive or spiral dissection, we can put a stent in.
For non-ACS patients, how long do you keep them on DAPT if they need DAPT?
Well, I think that's probably one of the advantages as well, and Bruno will know this better than me. But I mean, for me, I think we have an opportunity to give a shorter duration because, of course, why are you giving the DAPT? Of course, with the stent, it's clear why we're giving DAPT. For this setting, beyond a month, I'm not sure why we necessarily would give DAPT, but I know that's purely empiric.
Yeah. While doing primary angioplasties, what you did for right coronary artery, a drug-coated balloon. So the thing you said that in primary angioplasty there is a lot of thrombus. So when we are implanting a drug-coated balloon, we might end up delivering the drug and in the thrombus. So why not we do a simple balloon angioplasty, then wait for 2 days and do a delivery from the drug-coated balloon?
Yeah, I mean, I think if you don't mind and your patient doesn't mind having a second visit to the lab, that wouldn't be unreasonable. But I also think if you take a slightly different approach, which is you have slightly more liberal aspiration of the thrombus and you deliver a glycoprotein 2B3A inhibitor into the coronary artery and you do your predilatations until you've got a wide open vessel and no obvious visible thrombus, you're probably going to get good delivery of drug to the vessel wall. So, so far I've been very happy with the results. We will see in a more systematic manner when we start a trial.
Thank you.
Indeed, it's very important that you don't put the balloon as a direct balloon. You have to prepare the lesion, dilate, get flow, and then you go with your DCB. Well, we have time for one more question, do we? Yes.
Thanks for the nice presentation. I guess one of the most important questions when dealing with DCB, how much of a dissection do we accept? I think this is the most hurdle. I do DCBs, but still I'm not sure how much I can accept dissections. What I hear from you, if it's not occlusive, if it's not spiral, that's okay. Whatever, how much it looks ugly on the angiogram. Is that correct? Because there are many different recommendations about the types and.
Absolutely. And I think, you know, traditionally people have said, oh, it shouldn't be more than a type B dissection. But actually, I've learned from Bruno and others that actually that may not really be the case. And that probably, and Bruno can speak to this if he'd like to correct me, if you have TIMI3 flow, and if you don't have either a spiral dissection or an occlusive dissection or extensive dye hang-up at the site of the persistent dye hang-up at the site of the dissection, then you should be okay to leave it. It's always a difficult situation because, of course, it's exactly what we'd immediately be reaching for a stent for normally. So it takes a big change of heart, change of mind to look at something like that and say, no, that's okay, I'm going to leave it. Yeah, and that will come with experience over years.
And this is the topic we will afford in the next presentation. Okay. You want to make a comment?
I want to make a comment because this is a very crucial point. That following our experience in SFA, so in also in below the knee cases, of course, SFA is not coronary, so the risk of total occlusion is completely different matter. But we were completely surprised because we make some very horrible angiographic final result using DCB, diffuse disease, diffuse dissection, and so on. We were involved in many studies, and the follow-up, even with the ultrasound, also the angiogram, was impressive. Why? Because there is a kind of remodeling, as we know, is a kind of
healing.
Proper healing of the vessel. So even in a diffuse disease and SFA, the long-term are very often very good. So this is something, of course, we can translate with some small properties to the coronaries, but it's something that could
that's
happen.
A great example because the risk of having total occlusion of FSA is totally silent, but you get experience living these ugly dissections, getting healed with time. And this is what Dr. Ong will tell us. Please, Dr. Ong, go to the podium. His talk is exactly related to how do we define a good result? I mean, how can we leave it as it is or don't accept the immediate result?
Thank you very much. So I think the question here, or the topic here is actually how to assess the result of the lesion preparation to tell us that, yes, this lesion can be treated with a DCB. Because usually in the DCB PCI, it's the last step of the PCI. So whatever damage or injury you have caused to the vessel, you have done it all before you deploy the DCB, and which means that the angiogram should not get worse, right? After the DCB, it should be either the same or even a little bit better. Now, how do we assess? Well, if you look at most guidelines or consensus statements, they say more or less the same thing. So there are three things that we look for. Firstly, we look at the residual stenosis, and everyone talks about the 30% residual stenosis. We talk about non-flow limiting dissection. This is an international consensus, but some other guidelines would say no, type A and type B, not more than type B dissection. But more or less, I think they are saying the same thing. And now we talk about flow. TIMI3 flow was originally talked about in the earlier recommendations, but now we talk about using FFR to assess flow after the lesion preparation. However, these three criteria is a little bit problematic, right? Because if you talk about the 30% residual stenosis, it's a bit of a subjective thing. It depends on your angiographic view, right? And the 30% you are talking about is based on eyeballing of the angiogram. So it's not necessary to do a QCA or to do intravascular imaging. So what might look like 30% to 1% to another cardiologist might look more than 30%. So if you look at this lesion, well, this one is a bit more straightforward. I think most of us would probably agree that it's well, around 30%, right, or less than that. And this is the final result after lesion preparation, after the DCB. And this is a follow-up. Oops, sorry. And this is the follow-up angiogram 3 months later, showing positive remodeling. This one then is a little bit more difficult. Is it 30% or is it more than 30% residual stenosis? Some would say it's 50, some would say, right? A bit more controversial. But then this was treated with a DCB, and this was the angiographic result 3 months later. You can see the healing and you can see the positive remodeling. So in assessing for the 30% residual stenosis, I think you need more than one view, right? You need to look at it at least two or more views to be sure, because just like a lesion can be eccentric, residual stenosis can be eccentric as well. It might look worse in one view than the other. But we've realized over the years, as we do a lot of DCB PCIs, that it's not just the residual stenosis. And I think more important than residual stenosis is probably the floor. We find that the floor is more important. The TIMI-3 floor, right, is important. But then again, you can argue TIMI-3 is also subjective. Right? Some of you said, when you look at angiograms, oh, that's TIMI-3. Some said, that looks a little bit less than TIMI-3. Fortunately, nowadays, we can do it, we can be a bit more objective. Of course, you do not have to insert a pressure wire. Nowadays, life is made a lot easier by using angiogram-derived FFR. There are many software that can do it. CathWorks is one example. And just a short, simple, a minute or so, you can get the result. And if the FFR derived by angiogram is greater than 0.8, we can assume that the flow is good. 0.8 is the cutoff used in the international consensus. However, in our Asia-Pacific consensus, we use a cutoff of 0.7, based on the understanding that 70% of the cases will undergo positive remodeling. So an FFR of 0.7 at the end of procedure, when you follow the patient up subsequently, actually it might be better than 0.7. Huh? Yeah, so we are a bit more courageous in the Asia-Pacific region, but if you want to follow the international recommendation, the cutoff is 0.8. This software is very interesting. I think it's available in the Medtronic booth, so if you want to have a look at it, you can go to the booth and look at the software. Huh? So as I said, the flow is important, all right? The flow is important. And this brings into question then the dissection, because this is the third parameter, isn't it? No flow limiting dissection, and some guidelines say not type A or type B. Now what is type B? Type A means a line parallel to the lumen that clears with contrast, as the contrast in the lumen clears. So is this type B or not type B? Because the definition does not tell you the length. 10 millimeters is type B. 30 millimeters is also type B, right? So this is multiple dissection is also type B. So is it type B or not? Well, this lesion we thought was type B, treated with DCB. And this is the angiographic result 2 months later. And you can see that dissections have healed and there's luminal gain, right? In the whole LAD that was treated. Again, the flow is the important part. The flow is important. And so, as you have heard from the first lecture, the lesion preparation is crucial. Right? The importance is to get good lesion preparation, and your pre-dilatation balloon must be able to expand fully with no wasting, no dot bond effect. Right? It has to open fully. So we used to say that undilatable lesion cannot be stented. The same thing it applies to DCB. An undilatable lesion should not be treated with DCB, because a DCB is not magic, right? If a residual stenosis due to concentrated calcium, that drug in the DCB is not going to dissolve the calcium over time. It's not going to happen, right? So that lesion has to be opened before you apply your DCB. The dissection must be not flow limiting or potentially flow limiting. So if you look at the pattern of the flow, then if you're worried, then of course that's not suitable for DCB. But the flow is flush and fast and very good. It's not flow limiting. If you have problem trusting your eye and to tell you whether it's the flow is good or not, then of course you do a functional assessment, either using a pressure wire FFR, or you can use angiography derived FFR, and there are many softwares you have, like the one you've just seen, the FFR NGOs from CathWorks, but also you have QFR, VFFR, MuFR, so many FRs, right? And they're all more or less the same, right? Okay, more or less the same. So if the assessment is good, then the flow is good, right? And so this 30%, again, is something, as I said, subjective, and actually it's it's not a no, yes or no completely, right? It can be more than 30%, but you can still accept the result. Thank you very much.
Thank you, Dr. Ong. Well, let me say, I think that the degree of dissections that you are accepting depends on your experience, and your experience comes with age. Unless you are more than 100 years old, I think that very few people would leave this dissection as you did. But of course, this is what you are invited to show us, because I'd like to ask you to raise your hand who would have left this LED without stent, without a stent. Okay. And neither I would have, I'd say. And this is why, okay, flow, it's okay, but if you take a measurement of these residual stenosis, it's not less than 30%. It's practically totally occluded. So this is not the vessel I encourage my fellows to leave. So this is a very, very nice example to discuss and to go back to the main questions that you have made. Bruno, you are probably the most expert in this field. Would you leave this? You said yes.
I said yes. I said yes, not to stand it, but I would not have been. For me, it would not have been okay to leave it like this. I would have used scoring cutting balloons to modify the dissections, which works frequently very well to make it look not that ugly at this look.
Cambis, you are an expert operator of very complex procedures. I mean, which is your opinion on this final result? Acceptable, not acceptable?
No, the final result is quite good. The question is, would I have leave it or not, right? And honestly, if I include those patients in a trial, yeah. But without a trial at the moment, no. So because it's a proximal LAD and also different as a CTO. A CTO has collaterals, right? But here, I mean, I would put a stent, but anyway, I mean, it's quite interesting because it's a very, very large dissection. You never know, even if you have this same-day discharge thing in many centers and countries nowadays. So if you can follow up them for one night, if you are in a trial, it's a little bit different. You explain the patient, you have informed consent. But upfront, probably I would even put a stent, even if we do a lot of DCBs. Yeah.
Well, Bruno said something very important. I mean, even in this ugly dissection, if you said cutting balloon, you will modify the dissection and then you retry with the DCB,
and then you put
or
a
leave
stent.
it there. And then you put a stent. Nah, come on, we are trying not to put it. So the trip of the cutting balloon, can you please explain that?
No, the point is, if you see such a dissection in angiography, so that this is one big flap which is there, and this can close the lumen. But if you make it into smaller cuts, then you can easily put it to the wall, and that's my experience. At least that works very well.
Wow, this sincerely, I didn't know about that. This is did you know about that?
In the way of preparation. So once again, I don't want to bore you with about this SFA, but it's a clear example, exactly what I said. So huge dissection, nice flow, leave it. Of course, in SFA it's easier, but in the coronary sometimes happens. We are full of cases like that. We decide not to put a stent for many reasons, maybe surgery or something like that, and the vessel repair itself. So it's something we definitely don't know. We need studies, of course, but it's something that could happen.
It's a psychological matter.
Yeah,
I mean, if you put a stent and the stent
you mentioned the fellow, Flavio, and when they ask me why I don't have to put a stent, my answer is always why not?
Why not? Yeah, well,
so
we are
know,
discussing
why
this.
not?
This is what we are discussing. Yeah. When the stent occludes, you blame the stent. It's thrombosis of the stent. If this vessel occludes, it's your fault, and you feel guilty. So this is a psychological issue that we need to deal with, and you deal with it with experience. You have a question, yeah?
Okay. So if the residual FFR is more than 80%, is less than 80%, would you go ahead, maybe do an NC and DEB again, or would NC somehow affect the results of the first DEB you've done? Or you would go ahead, stent it straight?
Right. Before I answer that question, can I just make a little comment about the dissections? Because we're all alarmed by the dissections that we can see angiographically, and we are comfortable if we don't see the dissections angiographically. But if you have to do intravascular imaging, all of them have dissections. Yeah, and some of the dissections intravascular imaging can look quite horrible. So don't do intravascular imaging when you do DCBs, PCI. And other than using clotting balloons, one other trick we have done is actually to redeploy the balloon and leave a long balloon inflation. You might leave for 1 minute, 2 minutes, or even longer, and sometimes that at least creates a more beautiful angiographic result and give you greater confidence to finish off with a DCB. With regards to the FFR of less than 0.8, then you need to review back on our lesion preparation and ask ourselves whether the preparation has been adequate or not. And sometimes with the fear of causing dissection, we might undersize the balloon. So if we have undersized the balloon, then you go in and do fuller dilatation, balloon to vessel ratio of 1:1, and sometimes with that you can get a good FFR subsequently. Yeah.
Can we treat 2 lesions with 1 DCB? I mean, is there still a drug on the balloon after first inflation?
The answer is no. Yeah, there won't be enough drug left for the second lesion.
Thank you very much. I'm Abdullah Shah from UAE. Actually, I use DCB on all my cases, and for the last 3 years, I've used only 3 stents. So I think it's always in a meeting like this, it's very easy for us to show us only the nice cases. But I think the second case which showed us, I think that's where the learning is. People worried of that kind of cases. I think you should have just spent more time before you put the DCB to get things are healed, then you put the DCB. I mean, of course, nobody will, that's where argument happens. You cannot leave something like that and just with a DCB. I think you should work more on it than to do a DCB. So DCB is a great.
We have time for 2 quick questions, short answers. Who is it? You?
Can I?
And then you. Okay, 3.
Well, my question is, how long do we have to pre-dilate? I mean, do you think that if we dilate longer, 30 seconds, and then repeat the dilatation in a second dilatation, this should reduce the rate of dissection and improve the results? I mean,
Who are you addressing the question? Who is going to take it?
The duration, we found that the duration of balloon inflation actually does not reduce the rate. So it actually reduces the incidence of recoil. So if you have recoil, then you go in and redilate and leave the balloon on a bit longer. Sometimes it can be up to a minute or longer. Then you can actually overcome the recoil issue. Yeah. The dissection, as I mentioned, yes, you can make it angiographically look better. Yeah, doesn't mean that the dissection is disappeared. It doesn't. It has been created. It's been there. It's there. You can't make it disappear. Yeah, but angiographically it look better. Yeah.
In a patient with this kind of results, with a very huge and long dissection, for how long time do you prolong the DAPT, and you make another kind of medication in the treatment, like vasodilators?
Well, I'll tell you our practice, but I'll like Prof. Scheller to...
This is for Bruno. Bruno, go. Yes.
It was about DAPT duration.
Yes.
So we are in the evidence-free area. The recommendation is 4 months DAPT in general, the usual 12 months for ACS patients, but we have to think about single antiplatelet therapy in high bleeding risk patients, which is under investigation, and we have to think about different DAPT regimes, shortened DAPT regimens for ACS patients.
And he asked about vasodilators. Do you give vasodilators in chronic?
No.
Something specific on this case with this kind of dissection.
Yeah,
it's your time.
Coming to the duration of the inflation of the drug-coated balloon, how long? 30 seconds, 1 minute, 2 minutes. That's number one. And number two is, for example, you have a proximal LAD, left main bifurcation. What's that? You have a lot of experts here. So you do for a de novo lesion, if it's if you think it is suitable, do you do for that? You don't put a stent for a prox LAD or a distal left main.
Balloon dilatation is usually 1 minute. That's a standard recommendation. But if the patient can tolerate up to 1 minute, I think for most balloons, up to 30 seconds is probably sufficient. So that's the duration of DCB inflation. With regards to austere LAD or proximal LAD, usually the disease will extend to a left main. And we tend not to use DCBs for left main for a couple of reasons. Number one, the left main is usually very large, and you don't have DCBs of that diameter. And number two, sometimes if it's a very dominant left system, it's very difficult to leave a balloon inflated in the left main for 1 minute. But it all depends on how the patient tolerates during the lesion preparation. So generally, for austere left main or disease that extends to the left main, we tend not to use drug-coated balloons. Yeah.
So the vessel size is the key negating factor for you not to choose a DCB. If the vessel is large, no DCB.
If you don't have a balloon of that adequate size, yes. But now DCB is up to 4 millimeters, and I think there's one that's up to 4.5 millimeters in diameter is available. However, again, we are talking about evidence there. At the moment, no evidence. There's an ongoing trial now looking at large vessels, de novo lesions, randomizing, comparing between DCBs and DES, and that will provide us the answer. Yeah. But from our own experience, from our center, it works with large vessels as well.
So it's great to see all this interest, but we have to move into interest of time. Last speaker will be Professor Scheller, who, as you know, is a pioneer in this field and will explain us which are the rationales of these benefits at the long term.
Yeah, thank you very much. I have to do it now in 5 minutes, I think. Hopefully I can do this. These are my disclosures. Okay, why are we talking about DCB for de novo, despite the fact that it is not approved by the guidelines? Because we have an event rate, stent-based event rate of 2 to 3% per year, even with the modern generation, and so far as we know, this never stops. The basic principle has also been discussed. DCB only means lesion preparation is the key of your whole procedure, and after that you can decide if you use DCB or a DES, and that's a good thing. Dissections we have already discussed. We have this old classification, which may be not appropriate, but we have so far only this classification, therefore we use it. What we know, meanwhile, is that type C is not type C. We have different types of C, therefore the experienced operators also include type C dissections for DCB treatment. Meanwhile, if the flow is good and other criteria are fulfilled, dissection seal, this has been shown by Bernardo Cortese very elegantly. The fear of acute vessel closure is not there. Why? Because we sort out the lesions with high risk for acute closure by our lesion preparation. And number two, we have dual antiplatelet therapy, which made stents safe in the 90s. That's forgotten by many people. For example, here in the basket small 2 angiographic sub-study, there was no single vessel closure in the DCB arm, but a relevant number of closed stents in the stent arm. DCB treatment is safe. No cause of concern with respect to paclitaxel. This is our coronary meta-analysis we published a few years ago. You can see myocardial infarction rate with DCB only is significantly lower within the first year. This means the risk of acute vessel closure is not there compared to stenting or other modalities, and there's no signs of increased mortality. What we gain is vasomotion, which I think is very important, because if we talk about differences in angiographic outcomes between stents and DCB, we have to be aware that the stent diameter is fixed. It cannot adapt to the flow that is needed in this typical situation. And therefore, if we have a lower MLD in DCB, does not mean that in DCB-treated area under exercise there is no better flow. That's another thing we have to be aware when we discuss the results of mechanistic trials. Dissection treatment. DCB treatment allows to simplify the treatment of bifurcations. For example, here in this case from the PEPGAD-BIF trial, pre-dilatation of both branches, DCB on the one, then in the other arm, and that's it. You can accept here a not perfect result, but at 6 months you see the dissection has healed and the vessel has gotten bigger. And in this case, we saw also that the amount of plaque burden was more than 50% lower in the treated area than in the angiographic healthy parts that were not treated by DCB. That's very interesting. We see overall at 4 months a shift in the MLD distribution from the left to the right with paclitaxel-coated balloons, and this is unique for DCB treatment. You can see it with no other treatment modality. And the mechanism is mainly a growth in total vessel area, but also some regression of atherosclerosis, and this is the concept we are talking about at the moment. An example here, treatment of the circumflex artery, including this large side branch with a single DCB. This is the final result, acceptable. 5 months later, you see that the DCB-treated area has the best lumen in this whole part of the vessel. This is an angiogram from a very small lady with a small LAD treated with 2.0 DCB. This is the primary result, maybe not 30%, maybe more than 30%. And this is 15 months later. You can also see that the vessel has gotten bigger without the need for a very small stent. What we know from the PTCA is this axiom that the more you gain, the more you lose. This means the better lumen you gain with angioplasty alone, the higher the late lumen loss is. This is not anymore true when using paclitaxel-coated balloons. This is from the Transform 1 trial. You can see that with a higher dissection volume, the late lumen loss is decreasing. And that's really new. This means you can be aggressive and you can accept dissections because your outcome will be better. Physiology guidance has been discussed before. I will skip this. We have some meta-analysis now. This is from Bernardo Cortese, the Andromeda patient-level meta-analysis, which is under preparation for publication. Here you can see the comparison between DS and DCB only in terms of MACE. And here we see clearly that at longer term, there is a benefit in hard clinical endpoint or maybe benefit in hard clinical endpoints. Long-term data is also there. This is from Simon Ecclesholl's group, 1,500 patients. And here you can see that at 5 years, there is a tendency towards lower event rate in DCB-treated patients than in drug-eluting stent-treated patients. But it's not an either-or. It's more the question, which strategy do we prefer, for example, for the treatment of multivessel disease. And this is very elegant work from Professor Shin's group from Korea. They looked at the strategy of implanting a stent in every lesion in multivessel disease versus the DCB-only strategy, which means that on a per lesion basis, the lesion gets treated with DCB or with a drug-eluting stent. And here you can see that in multivessel disease, there was a relationship of 2 to 1. This means 2 of 3 vessels, lesions were treated with DCB, 1 was treated with a stent. And in this analysis, you can see at 2 years, the event rate was significantly smaller with this hybrid approach than with the pure stent approach. This has to be confirmed in prospective randomized clinical trials, but I think it's very encouraging. Now, at the end, a case that it may be provocative for some of you. This is proximal LAD stenosis in a young lady, 56-year-old female, a physician colleague of mine, and she was doing extreme athletic things, mountain climbing in the Alps, and she had no risk factors, but she had this tight LAD stenosis. I treated it with a scoring balloon and a paclitaxel-coated balloon. This was the result with some dissection. You can leave it. And this is the CT scan 6 months later. And you can see in this area we have an almost healthy vessel. And that's what I think it's very important, especially for younger patients. What about limus versus paclitaxel? Much discussions. Only one thing. Paclitaxel is cytotoxic in tissue concentrations above 100 nanograms per milligram. It is not the case below this threshold. And very similar to sirolimus, and that means in the case of DCB, we are clearly in this area and not in the cytotoxic area. But we have a different distribution in the vessel wall. Paclitaxel accumulates in the media, adventitia, and that may be the reason why we see this lumen enlargement, especially in paclitaxel-coated balloons. For limus, we have different technologies. Here, magic touch with very low persistence of the drug in the vessel wall, and you know that it did not reach the primary endpoint in the Transform 1 trial against the paclitaxel-coated balloon. Another technology we are working on is clearly better in terms of persistence, but also with this technology we see this effect of late lumen enlargement more pronounced with paclitaxel-coated balloons than it is the case with sirolimus. So my fast conclusion, I hope I gained some time. We have to deal with stent-related events in the range of 2 to 3% per year. And that's the reason why there is need for options to reduce the number and length of stents. DCB only is the way to go. Careful lesion preparation improves the outcomes of DCB and DES. And the decision which device you use is based on a per lesion basis, depending on the result of your lesion preparation. You gain late lumen enlargement, vasomotion, and you have no stent-related complications because there is no stent. At this time, we can say that paclitaxel remains the standard for DCB. Thank you very much.
Thank you, Bruno. I think that this summarized very well the basis on which we have been discussing. I will not be showing the slides, but 3 concepts are those you have to take home. There is nothing like direct DCB. It's like putting direct stent in a calcified lesion. Prepare, 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 and then if preparation is good, you go with DCB. There are no contraindications. There are no lesions that cannot be considered. Of course, we have no evidence on bifurcations, on left main, on CTO, but the only decision is taken after good lesion preparation. And the third one, the follow-up, is much better than the immediate result. So you have to trust in the therapy. And we don't say that you have to do angiographic follow-up, but if it happens that you have it out, you call back the patient, you will be much, much more reassuring when you see the long-term result. Thank you very much for the participation. Hope you like it, and have a good day in Paris.